Thank you. A little bit late, but at least now I should take the opportunity to thank for the invite. It's a great pleasure to be here and talk about the special pathophysiological scenario of TR in pressure overloaded right ventricles, and especially what treatment could mean in those patients, or whether there is a risk and how it does change pathophysiology. If we consider TR only from a pathophysiological point of view, what does it mean for the right ventricle? It's actually a low resistance outlet for the right ventricle. It's a little bit easier to push the blood into the right atrium rather than forward into the pulmonary artery, especially if pressures are high, either because of high resistance or because of a fixed resistance. So it could be a good thing for the right ventricle, but obviously it causes right ventricular volume overload. If we treat TR, then we sort of close off that low resistance exit for the right ventricle. So that could increase afterload. What we also should do, ideally, we increase forward flow out of the right ventricle, now in the right direction, which if the resistance is fixed, should also increase right ventricular pressures. And the question is, could it actually cause any harm to the function of the RV and the patient? Now, let's first look at what the procedure does. What are the pathophysiological implications using MR, small numbers, but it's more about the concept. And obviously, when we look at tricuspid regurgitation fraction, as expected, we reduce that, we have less regurg, and that causes a reduction in right ventricular preload. And as a consequence, we see that the right ventricular end diastolic volume, they get smaller. We see no change in right ventricular end systolic volume. Some of these changes are very similar to what we see when we treat pulmonary regurgitation. Right ventricular stroke volume, as a total stroke volume, gets less because we get rid of the regurgitant volume, which before went into the right atrium, but the effective right ventricular stroke volume, so what's actually ejected into the pulmonary artery, increases. So it is true, there's going now more blood into the pulmonary artery. What does it mean for right ventricular pressures? To understand that, we have to separate the patients into three different cohorts. There's one cohort in green. Those are patients that had no high RV pressures to start with, and we see very little change. Then we have one cohort of patients that had high RV pressures, so because of high pulmonary artery pressures, and we see, despite the fact that we closed off the low resistance exit, and despite the fact that we push more blood into the pulmonary artery, that RV pressures go down, assessed on echo. Well, this is a little bit surprising. And how can that be explained? I will give you an example how we might be able to explain it. A 73-year-old male with typical signs of right heart failure, chronic AFib, kidney disease, and diabetes. We've seen that already, what tricuspid regurgitation does on physical inspection. When we then do an echo, we can confirm that there is, in that case, massive tricuspid regurgitation, also invasive assessment. We do have a ventricularization of the right atrial pressure tracings, and we see high PA pressures. So in that case, PA pressure systolic were about 80. What we also see is that left ventricular function is preserved. We have high wedge pressures in that patient, so there are certainly high postcapillary pressures, and we see high left ventricular filling pressures. So in conclusion, this is a patient with heart failure with preserved ejection fraction or left ventricular diastolic dysfunction. This is the reason for increased postcapillary pressures. As a consequence, the patient has high RV pressures, and that's the pathophysiology in that case. Now, what's the combination of postcapillary pulmonary hypertension and tricuspid regurgitation? So diastolic dysfunction is caused in the elderly because of increased stiffness of the left ventricle, of the left atrium. It increases the filling pressures, postcapillary pressures, RV pressures. That causes the RV to dilate. We have TR. And then we have another phenomenon kicking in. And this is shown on MR on the left side. And this is a quite unfavorable ventricular interaction. The RV, because of its dilation, gets bigger. We have abnormal septal motion. The septum is bowing to the left. And on top of diastolic dysfunction, that septal bowing is further restricting left ventricular filling. So this is a certain a vicious circle, which ideally can be broken and interrupted by a successful transcatheter or therapy of TR, as in this case. So we were able to reduce TR to a minimum. We see that the right ventricle gets much smaller. And despite the fact that the intrinsic stiffness of the left ventricle has not changed, the left ventricle has now more space to accommodate blood and to expand in a slightly restricted pericardial space. So we improve ventricular interaction, and that could be one explanation why in some cases we can actually reduce right ventricular pressures, because we have less postcapillary pulmonary hypertension. And we then finally could confirm that by using an invasive technique, pressure volume loops, reconstructing the stiffness constant of the ventricle, and we see the left ventricle, volume is now, after the procedure, is filled more, but despite that, we have lower filling pressures because we got rid of that unfavorable ventricular interaction. And that explains why actually in some patients when we treat TR, we can actually reduce RV pressures rather than the other way around. And then we have one cohort of patients in red, and there we see a small increase. Again, those were patients who had high RV pressures invasively, but they had low pressures on echo. So there's a certain discordant diagnosis, invasively high pressures, on echo low pressures. And here you can see the correlation between the echocardiographic estimation of RV pressure and then the invasive pressures or PA pressures. And you see that it correlates, but it's all over the place. There's some patients with low pressures with both techniques. There's a certain group of patients with high pressures on echo and invasively. And then there's a very specific cohort of patients. They have high pressures invasively, but on echo falsely underestimated PA pressures because of the large cooptation defect. So the fundamental principles of echo estimation of RV pressures, that does not work anymore. And by the way, this is also an indicator of worse outcome as shown here in red, but it means that assessing RV pressures in patients with TR before and after is non-trivial, because we can never be sure that we're measuring the right thing. But let's say that RV pressures might go up in these patients with high RV afterload. Is it a terrible thing? I guess many of you have seen that picture from Braunwald suggesting that the RV is extremely susceptible to any increases in pressure. Unlike the left ventricle, as soon as RV pressures go up, the stroke volume goes down immediately. The RV cannot cope with pressure at all. Now, the problem with that illustration and demonstration is that it is done in absolute terms. But if you plot the change in RV stroke volume to the relative change in pressure, and that's done on the right, you could argue that there's not so much difference between the ability to adjust to pressure of the RV and the LV. The problem when we assess RV function is always that we see the current state under the certain loading conditions, whether it is abnormal, whether it is pressure overloaded, or whether it's volume overloaded. But you don't know what's the true potential, what's the intrinsic function of the RV. And one way to do so is to look at RV contractility. We can't do it in clinical setups, but it's a nice research tool. It can be assessed invasively with conductance catheters and acquisition of pressure volume loops. And when we do so, we can reconstruct a tangent at the end diastolic pressure volume relationship. And the steeper this line, the better the ventricular contractility. So the more potential the ventricle has to perform, given that we give the ventricle the best loading conditions possible. And when we look at pressure overloaded hearts as opposed to controls or volume overloaded hearts, you can see that those with pressure overload, they had the highest contractility. So a quite marked adaptation to pressure overload with an increase in contractility. So it might be that pressure overload and the ability to adjust to it was underrated. The RV can do a little bit better than we might think. Another remark about how we assess RV function. Obviously, we very often do with TAPSI because it's so easy, especially when we don't have magnetic resonance imaging or 3D imaging. But obviously, unlike the healthy RV myocardium as soon as the RV is susceptible to pressure or volume overload. Longitudinal function goes down first, but might be compensated by radial and circumferential contraction, and this is exactly what we see in patients with tricuspid regurgitation. So as a first sort of stage of disease, we see good shortening, longitudinal shortening, and then in a medium stage of disease, the longitudinal function goes away, but it is compensated for by radial contraction and shortening. So type 1 and type 2 have the same ejection fraction, they probably have the same function, but if you only look at TAPSE as a longitudinal marker of contraction, then you totally underestimate the function or overestimate the dysfunction. And then obviously when you lose longitudinal and radial function, then you have the worst state, and that's also the group of patients with the worst prognosis. So assessing RV function in pressure overload is, again, complex. We do have some MR data in our cohort suggesting that ejection fraction stays the same when we treat tricuspid regurgitation. There's also some surgical data where they used MR and looking at ejection fraction, again, no change. And we do have also some data suggesting that in some, we can even see some improvement in right ventricular function. Now, again, this is TAPSE with all the limitations, but a positive signal. And the explanation might be that as much as sometimes one is focused about RV pressure overload, obviously the volume overload is also quite detrimental, and we reduce right ventricular volume overload and might therefore improve myocardial fiber stretch. What's important to realize that with these transcatheter techniques, in most patients we reduce TR, but we don't abolish it in full. So there's always some sort of low resistance exit which we leave behind. Not liberally, but only because we're not good enough with the intervention. But that's how it is from a pathophysiological point of view. Now with replacement, that will be different, because there we abolish the regurg in full. There is no low resistant exit for the RV anymore. And the question is, do we have a higher risk now when we use valves in these patients? We don't have the answer yet. You've seen the valve and how it works, so I don't have to go into detail about that, but I can tell you that it does what it should do. It completely abolishes TR in almost every patient. And there is some data from surgery also showing that obviously replacement reduces right ventricular ejection fraction, but repair does very rarely. And the question is that due to the changes in right ventricular pathophysiology, in right ventricular loading conditions, or might it also be due to the fact that such a valve has a certain size, it certainly interacts with the RV myocardium, and as compared to such a repair where we only have a small clip not touching any of the right ventricular myocardium. So these are unanswered questions. So in summary, the risk of RV failure after treating TR is low. Because RV sensitivity has been overrated in the past, I dare to state contractility is increased in RV pressure overloaded ventricles. So these ventricles, they are adjusted to the high pressure. And if we just add a tiny bit of more pressure, it is normally well compensated for. At least that what the clinical observation suggests. RV pressure increases after TR reduction only in very few. RV global assessment should be based on more global parameters rather than just a longitudinal assessment, and the benefits of less RV volume overload might be underestimated. We will see what it means for valves, but at the moment we can state that acute RV failure is almost never seen in these patients. Thank you.
Thank you very much, Philip, for this great presentation. Are there any questions from the audience?
May I? I really enjoyed your talk. It's very sophisticated, and the way how you can repair the valve by one or the other way is just fantastic. Really appreciate that. I have a problem, and I want you to answer that if you can, with etiology, with the causes. as we've seen, and you told us this, that AFib could be a reason, a cause for dilatation. But there's multiple causes for dilatation. It's almost never the structure of the tricuspid valve. So that's most fine. And we are very focused as congenital heart surgeons with the tricuspid valve, because we basically do all our repairs through the tricuspid valve, and it's easy to repair if there's no structural thing. But if you have a problem, for example, and we face that's why I'm asking, with the left ventricle that you cannot solve, and if you have a problem with the pulmonary vascular system that you cannot solve, and the tricuspid regurgitation is just the answer to the problem, you will not fix that by just repairing or replacing the valve. So what do you think about it?
I totally agree, yes. And we see that, for example, pre-capillary pulmonary hypertension, those patients have a certainly worse outcome than those with post-capillary. And also, as you said, if we have a still left-sided heart valve disease and we can't treat it for some reasons and we only treat the right side, then again, outcome is much worse than in the other patients. Having said that, symptomatic benefit we see quite often. I mean, right heart failure is just a terrible thing to have, and many of these patients report symptomatic benefit, much more certain than when we treat the mitral valve, I have to say. And what we never know, or at least we don't know it as yet, is what would happen if you don't do anything in those patients. But there is no doubt that that scenario you described much worse outcome than the other group.